Now we're going to discuss asthma. This is a topic that's good for step 1 as far as pathophysiology, step 2 as far as diagnosis, and step 3 as far as management. This is going to be a reversible disease. It's characterized by reversibility, bronchoconstriction, airway edema, okay, and mucus production. So what happens is there are many triggers. Whatever the trigger is, it causes bronchoconstriction. So right there, the airway is already narrower. In addition, the inflammatory response causes some airway edema. That makes the airway narrower. And lastly, part of the inflammatory response causes a lot of mucus production. So it plugs up the airways. That makes the airway narrower. So these three things contribute to air trapping. As the air goes out, since it's traveling at different speeds, different sized airways, that's when you're going to hear wheezing. Many times patients will cough to try to get those secretions out. Not everything that wheezes is asthma. And asthma doesn't always wheeze. You have to remember that. There are other things that can cause wheezing, and sometimes asthma is coughing or exercise-induced shortness of breath, things like that, or coughing. There are multiple triggers, and it's basically just an imbalance between the factors that cause bronchoconstriction and the factors that cause bronchodilation. It can be insidious. It can start out as a mild cold or cough, and then after the next couple of days, they start getting worse. Or it can be acute after an exposure to smoke or to cutting the grass, things like that. Look for a past history of wheezing. That's easy. If they've had recurrent episodes of wheezing, you're pretty much going to diagnose that with asthma. Now, don't forget that children under 2 years of age can have recurrent bronchiolitis, and that can cause wheezing. So that's another part of your differential diagnosis. Look for a past history of allergies. So if the patient has allergies, then they have a certain type of immune response. That puts them at higher risk for asthma. Look for a past history of eczema or atopic dermatitis. All of these things kind of have similar mechanisms, so that puts them at higher risk for asthma. There's a specific entity called exercise-induced asthma. These are patients that are fine until they actually do some physical exercise. Then they start coughing and they get short of breath. I remember years ago a girl I was coaching in soccer. She couldn't play offense. I wanted her to play offense. She says, "I can't run." I said, "Why can't you run?" She goes, "I just can't." I got further history from the mom, and the mom says, "Oh no, she doesn't have asthma." We talked some more, and she said, "You know, whenever she dances, she gets short of breath." I said, "Well, you better go see your doctor." Well, her doctor put her on some bronchodilators. The next soccer game, she was running all over the field. I had to bring her back because she was too far up. So that's exercise-induced asthma. Look for exacerbations or symptoms of coughing, shortness of breath, possibly wheezing with exercise. Also look for a family history. If there's one person in the family with asthma or allergies, there's a very high probability that this child or someone else in the family will have asthma or allergies. There is no one best test to say, aha, you have asthma. It's usually a clinical diagnosis. There are some ancillary tests that may be helpful. Always look for wheezing. In the acute exacerbation of asthma, you will hear wheezing. It's an expiratory sound, different pitches. You will listen for a prolonged expiratory phase. They may have decreased breath sounds. They might have rales or rhonchi suggestive of upper airway problems. And look for problems breathing, tachypnea, retractions, things like that. Sometimes the liver is palpable when you examine the abdomen. That's not because the liver is enlarged. That's because of the air trapping. The air trapping causes the diaphragm to push down. So it pushes the liver down, much more easy to palpate. Again, there is no specific test in children. You can do pulmonary function testing and all, but the younger children are not going to cooperate. You may have eosinophilia in the blood or in sputum. You can do some skin testing, but that doesn't tell you you have asthma. That just tells you have allergies to certain products. Again, pulmonary function testing, if they're cooperative, you can use bronchodilators and then retest them and see how they do, and improvement in FEV and things like that will be helpful. A chest x-ray during the acute phase will be helpful because it will show signs of air trapping. It'll show flattened diaphragm, increased intercostal spaces, ribs that are straighter out or flatter, but that's not pathognomonic for asthma. When the patient is normal, x-ray looks normal. Remember, there's a reversible disease, so this child, A, will not have clubbing because they don't have chronic hypoxia, as opposed to a patient with cystic fibrosis that develops clubbing. These patients are fine in between episodes. They oxygenate fine, their x-ray would look normal. The blood gas is very helpful during an acute phase of the attack, and you might actually get a question like that. In the initial part of the asthma attack, the patient will be basically hyperventilating a little bit. So your blood gas may show a normal or slightly high pH and a normal or slightly low normal PCO2. That's the early stage. During the middle stage of the attack, as it progresses, you will start to see that the CO2 is starting to rise. That's an ominous sign. That means that the patient's getting a little bit tired. Finally, in the late stage of the attack, not only is the CO2 high, but now the pH has dropped because you've used up all your buffer. So those are three excellent examples of how the progression of an attack following the blood gases. That could be a test question. This is a child with asthma, and again, sometimes you'll see some perihilar problems, a little bit of increased perihilar markings. Okay? Otherwise, the lung fields look pretty doggone black. And again, you can see the diaphragms here. These diaphragms are kind of flattened, and that's indicative of air trapping. Again, you can count ribs, and you can count a bunch of ribs. That's also indicative of air trapping. This is also very important, this table, so I really recommend that you spend some time with it. This is the classification table for asthma, and the next table will be how to treat them. Actually, the treatment is on this table. So we define it into mild, intermittent asthma. Everybody else is persistent. It can be mild, moderate, or severe. So it's all by the amount of symptoms, the frequency of symptoms. So we have mild, intermittent, and those patients are going to be treated with bronchodilators as needed. The others are going to be persistent, and the hallmark of treatment for these patients is going to be inhaled corticosteroids daily, right? And you can look at the daily symptoms and the nightly symptoms, and that tells you what you need to do for those patients.